Side disease type of disease that happens in children. So before we go to the main etiology, main clinical presentation of optic neuritis. So before dealing with the clinical features, I will deal with the pathogens. What happens in this? There is one problem in this, that is demyelination. There is a demyelination, because we know optic nerve is a myelinated tract. It's a myelinated white matter tract. So once there is demyelination, what happens? The fast conduction, what's called solvent conduction, is affected. That is affected. So once the solvent conduction is affected, then the stimulus perceived by the body, perceived by the eye, is delayed. That is delayed, and you have symptoms because of that. So, if we go by the clinical features, what can be the symptoms of optic neuritis? There is one more pathologically. There is one more. There is deposition of lymphocytes and plasma cells. Lymphocytes and plasma cells in the sheath of the nerve. Okay, so that causes an inflammatory cause. That causes an inflammatory demyelinating plaque, what's called lymphocytes and this plasma cells. So if we go by the clinical presentation, a patient is coming to the OPD, what he can have. So once a patient comes to the OPD, we see his vision is generally it is unilateral. Generally it is, but it can be bilateral. But 99% or 90% of times it is unilateral. Then we can have some, it can be bilateral. So if we go ahead, then there will be patient will be complaining of decrease in vision. He will complain of decrease in vision. What he will complain of? Decrease in vision. So suppose in one eye there is only figure 2 meters or 3 meters vision. Other eye has 6. And suppose now patient has everything normal. Everything, only one thing is here. That is the pupillary defect. That is the fundus is normal. There is a related afferent pupillary defect. Pupillary reaction on one side is affected. What type of optic neuritis it is? It's called retrobundle. Because the optic nerve head is not involved. It is behind. Optic nerve tract, optic nerve itself. And you will not see anything on the fundus. So only thing is what? Related afferent pupillary defect. So if we go by first we go about diminution of vision. What type of diminution of vision they have? They can have sudden, acute, or they can have subacute, or they can have prolonged, or like recurrent decrease in vision. 2 years back there was a decrease in vision, then it can come again, it can have again decrease of vision. So decrease of vision is the ordinal symptom of optic neuritis. It almost differentiates it from papilliedema, because in papilliedema the decrease of vision is not there initially till it reaches to the final optic atrophy stage. So that's the difference. And papilliedema is bilateral, majority of cases, and optic neuritis is unilateral. So these are the differences between them. So we have now a decrease of vision. And once we examine the patient, there is a relative afferent pupillary defect. Suppose it's a bilateral optic neuritis, right eye as well as left eye. What will be there? There will be ill-sustained pupillary reaction in both eyes. There will be ill-sustained pupillary reaction in both eyes. So then we do the other tests. What other tests we do? You should know what are the optic nerve function tests. First is the vision. Second is the visual field. Okay, third is what? Third is the color vision. And fourth is the contrast sensitivity. So these four are the optic nerve function tests. So first check the vision, then check the pupillary reaction, then check the check the color vision and then check the contrast sensitivity. If we check the color vision, that is grossly decreased vision. It is grossly decreased vision. So there are some things written here. There is decreased visual acuity. Then this term, this chromatopsia means altered color perception. It means altered color perception. Then apparent pupillary defect I told you. Okay? Then contrast, abnormal contrast, you can remember that. Rest of the things I will tell you about it. Then if we do a visual fields, they can have all types of visual field effects. They can have all types of visual field effects, like they can have generalized reduction, they can have scotomas, they can have altered pattern, okay, or they can have huge scotomas. So there is a varied presentation on visual fields, but the visual field is always abnormal. Visual field is always abnormal. Then if we go by the clinical test, there are two more signs in them. That sign is called, one is called Pulfric sign, and other is called Uthoff sign. Pulfric sign and Uthoff sign. Anybody can tell me what Pulfric sign? Because they have delayed conduction. So if we put something like a pendulum like this in front of their eyes, suppose who is moving like this, they will feel it is moving all around, a parabola. This is called pull friction. What is this called? Pull friction. Then other is called Uthoff sign. What's Uthoff sign? Uthoff sign is that decrease in the vision or decrease in the body symptoms like paralysis or whatever, that aggravates with exercise and temperature. Two things: exercise and hyperthermia or temperature. Remember these two things: exercise and temperature. There is worsening of the vision. There is a worsening of the vision, and there is worsening of other symptoms like a paraplegia or whatever. So this was about these two signs. And one more important sign they have in the eyes, they complain of pain. They complain of pain. In Papilliedema there is no pain. In this there is pain. Why there is pain here? Why there is pain? Nerve involvement, optical involvement do not cause pain. There is pain on the movement of the eye. Fibers? What is your answer for that? What fibers? You tell, you get up and tell. How many stand? Huh? Good. Very good. So they have the optic nerve sheath. It has contiguity with the superior rectus muscle and medial rectus. Two muscles, superior rectus and medial rectus. So once there is inflammation in the nerve and in its sheath, it will go to the along that sheath. It will go to the superior rectus muscle and medial rectus muscle. So once they look up or they will look in, either an elevation or an adduction. Two movements. Either elevation or adduction, they will have pain. Remember? Is it clear? In elevation or in adduction. Then if you go by that, what type of pain it is? Is the retroocular pain or deep orbital pain or an eyebrow pain? Three types of pain. Either a retroocular behind the eyeball or deep orbital, or they can have an eyebrow pain. So these are the two symptoms. decrease in vision and decrease in vision and pain. Signs में है there is a relative apparent pupillary defect. How we come to know clinically there is a relative apparent pupillary defect? Swinging flashlight test. Swinging flashlight test. Oh, okay. How we do the swinging flashlight test? So we put a hand in between because the light should not travel to the other. We put a torch here for 3 seconds, then 3 seconds here, then 3 seconds here. So on that it should dilate. On that it should dilate. Consensual will be present. Consensual will be present. On that, suppose right eye is do right. Once we put that in this direct, it will dilate. Once we put opposite, it will consent. So consensual will be present, direct will be absent. So we have to just put a hand in on the nose and swing the flashlight in 3 seconds each eye. This is called swinging flashlight test, and it elicits a relative apparent pupillary defect. So, if we now go, these are the symptoms. Then what investigations we do? First of all, before investigation, we will go how to treat it. Now there is optic neuritis and we want to treat it now because it's an emergency type of thing. So color perception is also absent, contrast activity.
So principal level.
Principal. Cube.
Regarding aid. Regarding aid.
So how to treat it? Because it's an emergency. This is sort of an emergency because patient has lost vision and it's an acute loss of vision. How we treat it?
Maybe the customer.
So first important thing is that we give them IV steroids. We give them IV steroids. But it is a pulse type of therapy. It's a pulse type of therapy. It's a high dose steroid therapy. What's called methylprednisolone. Methylprednisolone. IV methylprednisolone. That's given 1 gram. That 1 gram per day. 1 gram per day for 3 to 5 days. 3 to 5 days, followed by oral steroids of prednisolone 1 milligram per kg, that is around 60 to 80 milligrams per day for 11 days. And some people taper it for 3-4 days. But dose is this. We generally give for 3 days. But neurologists are more accustomed, they give for 5 days. So even if you give for 5 days, there is no problem. Only thing is, before giving steroids, you have to monitor few things. One is that you have to see the electrolytes, because there is a shift of electrolytes, sodium, potassium during steroid therapy. Other thing, you should do a basic parameter check like BP, hypertension, those things should be looked at. So this is the dosage of steroids. Remember this. And there is one alternative dosage that was produced by R.P. Center Ames. That's the ophthalmology section of the All India Institute of Medical Sciences. They have given it, because this 1 gram costs around 3,000-4,000 rupees. They have given an alternative therapy that was given dexamethasone therapy. That is, they have given 100 milligram of dexamethasone for 5 days. 100 milligram for 3 to 5 days. 100 milligram dexamethasone therapy for 3 to 5 days. So, this is the dosage and this is the treatment of steroids. And you should always remember, we should never give oral steroids alone. Somebody wants to not give IV steroid, he wants to give oral steroids. It has been shown it increases the rectal. So it is contraindicated to give only oral steroids. So the protocol has to be followed. You have to give IV steroid followed by oral steroids. Okay? That's a very important point. One more thing I forgot to tell you, I told you that retrobulbar neuritis, the fundus is normal. Now if there is fundus, there is a dysedema. What is that called? That's called papillitis. What will be the features of papillitis? Any idea? Right. Okay. So there will be a disc swelling. There will be a disc swelling. Disc will be elevated. There will be disc will be elevated. Optic disc margin will be blurred. Optic disc margin will be blurred, and the disc will be hyperemic. This will be hyperemic, and there can be vascular congestion on the disc, and there can be sometimes a hemorrhage, or there can be a hard exudates in the macula along the nerve fibrillary tract. Okay, so it is indistinguishable from papilledema. This is this swelling which you can't distinguish unless you look into other features of optic neuritis. There is a disc elevation with hyperemia, with blurred disc margins, with some hemorrhage, with some exudates in other sides, like macula, which is what's called a macular fan type of this one. So I told you neuroretinitis. So this is called papillitis. Suppose there is retrobulbar neuritis, you will not see all these features. There will be only related apparent pupillary defect. Okay. And in case of papillitis, you can have these symptoms, these signs. Now we have where diagnosed this optic neuritis. What investigation you should do? First, I told you visual acuity. Second, I told you visual fields. Okay. Third, I told you color vision. Fourth, I told you contrast institute. Then, what other investigation? MRI brain, right? Because it is an association with multiple sclerosis. So neuroimaging is very, very important here. And which investigation? MRI brain. MRI brain. And there is one more investigation that's called VEP. That's called VEP. What is VEP? Visually evoked potential. Visually evoked potential. Because there is leakage. There is a leakage of signal. So the first is in the VEP there is a positive wave, then you have a negative wave. Normally from base up to the top of one peak there is 100 milliseconds. How much? And in this there is a delay. In this there is a delay. Latency is increased. What's called implicit time. P100. P100 means the first positive wave. Time taken from base to the first top of the first wave. So in them it is above 120 milliseconds. So there is a delay in the conduction. So that was an abnormal VEP. And number 7, what will MRI show? That's very important. What is the MRI showing? Suppose we have this eyeball, and there can be a mild sheath problem, it can be damaged. What is the MRI show? MRI shows the increased strength, increased signal strength of the optic nerve. That will be more prominent. Suppose there is right side optic nerve, you can have, it will be more white. But there is one sequence what's called fat suppression sequence. What's called? Fat suppression, flame sequence. And number 2 is one more that's called T1 and T2 images. Okay, so generally they see in the T2 images. Come forward. Come forward. Come forward. Come forward. Come forward. Come and sit there. Sit on the first bench. So, MRI will show inflammation in the optic? No. That will show increased signal strength. And one more thing we should do is it should be contrast enhancement. There should be contrast enhancement. So these are the two things. We have some.
So, pictures compared to it.
Huh? No. So you will have an optic nerve. If there is a coronal plane, you will see in the center of the orbit there is a white spot, which is more prominent in the right eye than the left eye if the patient has right optic neuritis. And one more thing then in the brain, what do you see in the brain? You will see because the lateral ventricle or corpus callosum, there are some white matter lines, bands, okay? They have like radiations like this. They are called Dow furrows. What is called? They happen in multiple sclerosis. They happen in, because multiple sclerosis is basically a white matter disease, demyelinating type of disease in the brain. So the brain is affected in the white matter, just near the lateral ventricle, okay, just the lateral ventricle near the corpus callosum, There can be other regions which are subcortical, and they can be spinal also. So you can have an MRI spine also. So what will happen? There will be cortical lesions which are in the white matter. There will be like lines and like this radiating line, a type of furrows. Then we have some hyperintense spots will be subcortical. There will be subcortical, and in the spinal cord they will be isolated. They will not be contiguous. They will be isolated. One in the superior cervical region, one in the thorax, like that. They will be separated by the 2 or 3 vertebrae. So these are the 3 presentations of multiple sclerosis. One is subcortical. Most important presentation is these white matter, which are near the corpus callosum. Then you can have subcortical and you can have spinal. In the spinal, you have to remember they are discrete and they are separated, which differentiates from neuromyelitis optica. From the neuromyelitis optica. In the neuromyelitis optica, you have optic nerve involvement and you have spinal involvement. But the spinal involvement, you have more contiguous. You have more than bigger area of the spinal cord involved. There's around 3 or 4 like that. And they have optic nerve near the chiasm. So it will be sort of a retrobulbar neuritis. It will be sort of a there will be only RAPD. There will not be papillitis. Okay. So and they will have because it's near the chiasm. What type of visual field defect they have? They will have bitemporals. So neuromyelitis optica, you will have a chiasm near the chiasm optic nerve involvement. There will be only RAPD. The disc will be normal. There will be a bitemporal hemianopia. Half the temporal fields of both, and there will be continuous necrosis of the spinal cord. There is a continuous more than 3 vertebral necrosis in patch, most likely in the superior cervical region. So that's how we differentiate it from this. So if now there is now neuromyelitis optica, or there is this multiple sclerosis, or there is any other cause for optic neuritis, treatment is same, but I have told. Pulse steroids with this. There are some additional treatments, they are for multiple sclerosis. Like they have immunotherapy, they have interferon therapy. And there are one or two more drugs, interferon B1 alpha is given in this. So they are immunomodulators. one more you can have, and that is azothioprine, but that will be in the other group, emoji. What I told initially, myelin, oligodendrocyte, or ganglioside type of optic neuritis. In that, rituximab or azothioprine is given. So this was grossly about the optic neuritis. So I think to understand it, so if we see the differences between the two, before I go to the development, I will put some differences between the two. Optic neuritis, there is a decrease in vision. Okay? First we will tell optic neuritis is unilateral. Okay? Then this papilliedema is bilateral. It is bilateral. Optic neuritis is generally in young adults. In young adults, especially females, female young adults. Females are more common with optic neuritis because multiple sclerosis is globally more common in females. There is a high sex predilection for this disease, around 5:1. So young adults, it is disease of what? It is disease of optic neuritis. Okay? Papilliedema can affect any age. Then in the optic neuritis, you have related apparent membrane defect. In papilliedema, it is a late sign. It's a very, very late sign. If we see optic neuritis, it's unilateral. Papilliedema, it is bilateral. In the optic neuritis, if we see a neuroimaging, then there is a white matter tract problems. Okay, and in papilliedema, there can be a space occupying lesion or a malignancy in the brain. If in optic neuritis, the VEP is abnormal. In papilliedema, VEP will be normal. So these are some of the differentiating points between optic neuritis and papilliedema. Now we go to papilliedema, the second order. So what is papilliedema? Papilliedema is again a disc edema. That's a disc edema, but that is secondary to raised intracranial pressure. Secondary to increased intracranial pressure, CSF pressure. It's a passive type of thing. So you have to remember this. Because disc edema can be very, many causes. Like papillitis, like diabetes, like suppose diabetic papillopathy. You can have, suppose it can be part of vascular occlusions, central rectal vein occlusion, branch rectal vein occlusion. So it can be part of them also. But once it is due to raised CSF pressure, it is called papilliedema. It's called papilliedema. So how it causes papilliedema? Because you know CSF is formed by what? It is formed by the choroid plexus in the lateral ventricle. Then it is secreted, it goes to the second ventricle, it goes to the third ventricle, then it goes through the aqueduct, it goes to the fourth ventricle, then it passes through the three foramina, then it goes to the subarachnoid space and to the spinal space where it is absorbed. Okay? So what is the normal CSF pressure? If anybody will tell, I will have TV. Anybody can tell me? पता है किसी को कि नहीं? Anybody knows or not? जिसको पता है वो खड़ा हो जाए. Under 60. पता है? Under 60 नहीं है. 10 to 16. 10 to 16 or 18. 10 to 18 before. It is 10 to 18 silence. 10 to 18 centimeter of water. If we go by otherwise, it can be, if we convert centimeter to millimeter, then it will become 200 or 300 like that, or 180. So it is 10 to 18 centimeter of water. So if we go by the definition, by the causes of papilledema, what are the causes of papilledema? Because once we see papilledema, what comes in our mind? Tumor in the brain. You understand? But that is not the only thing. There is one, if we classify them, first is the idiopathic. First is the idiopathic. What's idiopathic? What is that disease called? Idiopathic intracranial hypertension. Idiopathic? It is a medical term. You should know. You have read in medicine. In idiopathic intracranial hypertension. What will happen there? Once we do a MRI or we do a CT scan, there will be nothing in the brain. Okay? Only the, if we check the CSF pressure by lumbar puncture, it will be raised. Okay? This is called idiopathic intracranial hypertension. This is the idiopathic cause of papilledema. Then there are secondary causes. Secondary cause number 1, posterior fossa tumors of the brain. Posterior fossa tumors of the brain. Number 2, most important, what we should do if we see a papilledema, what we should do? Check his blood pressure. Check his? Because blood pressure can cause papilledema. Do you know it? Yes, it can cause what's called malignant hypertension. And you can label a person as malignant hypertension only when you see papilledema. What is the definition of malignant hypertension? Diastolic BP above what? 120. I think some books cite above 140 and some 120. So, consistently, if it is above 120 diastolic, it will be labeled as malignant hypertension. And that is one of more cause of papilledema. So, remember this. Hypertension, very important cause. Suppose patient will have acute hypertension, you have seen papilledema, you are ordering CT, MRI, and you have not seen the basic thing. The patient is hypertensive or not. Third, it can happen in any case of inflammatory condition. Like what? Meningitis. Because there will be absorption of this from the subarachnoid space will be affected. Okay. Meningitis is a very important cause of what? Papilledema. Okay. Then one more cause is the congenital obstructions. Congenital obstructions of what? Of ventricles. There can be a sort of a stenosis of the aqueduct or like that. That's called congenital cause of the papilledema. Any other cause? Yes, that's called venous thrombosis. What sinuses we have in the brain? It is thrombosis in them. And what type of therapy is used if suppose there is venous thrombosis? What therapy you give? Anticoagulants, very good. So we will give anticoagulants. If there is a, how we diagnose this venous thrombosis? Yes, venography, not angiography. Angio is related to the arteries, and venography is related to the veins. Okay, that's called MR venography. That's called MR venography. By the way, I forgot one thing in the multiple sclerosis and because there is limited time. If we do a LP, what will be there? It will be oligoclonal bands. There will be oligoclonal bands. If we assess the cerebrospinal fluid. What is that oligoclonal band? They are immunoglobulins, and they are found only in multiple sclerosis. So if anybody asks you if you do a CSF or a lumbar puncture, what you will find in multiple sclerosis? You should say oligoclonal bands. So again, I will come back to papilledema. So we are talking of the causes of papilledema. So first of all, the idiopathic. We have seen some young patients. Idiopathic, gross papilledema in both eyes, and once we check every parameter normal, then the diagnosis goes on the basis of exclusion as idiopathic intracranial hypertension. Number second cause, congenital, malignant hypertension, congenital due to stenosis, malignant hypertension. Then third is the posterior fossa tumors. Number fourth is the cerebral venous thrombosis. So these are the most important causes of papilledema. Then there can be other associations also. There can be other associations, like somebody has a respiratory problem, he can have papilledema. Or if somebody has a renal disease, he can have a papilledema. Then there are some other, most important is one association in the young this time, is the sleep apnea syndrome. Sleep apnea syndrome. That has been seen to be associated with papilledema. So now the patient has, these are some causes. Then some pathogenesis I want to tell you. Suppose there is CSF pressure and it goes through the optic nerve sheath, it reaches to the optic nerve. How does it affect it? It causes compression, mechanical. So first of all, once the optic nerve canal, there is around the optic nerve there is a fluid. It compresses it. So once it passes the optic nerve canal, so it will cause a compression. Then once it will reach to the lamina tuberosa, once it enters the eye, there also it will cause compression.
What does it mean?
There is a compression from the back and compression from the sides. Okay. So once there is a compression, what will happen? What happens by the compression? Before that, there is an exoplasmic flow is affected. What is affected? Because there is a constant transport from the cell body to its exome, and from its terminal bulbs to the cell body. So there is an anterograde and retrograde. There is an anterograde and retrograde transport. Both are affected. So once both are affected, what will happen? It will cause. No, first of all, it will cause a sort of it will affect the nerve conduction. And it will cause a sort of swelling in the optic disc. It will cause swelling of the optic disc, and it will cause nerve damage, optic nerve damage. And once there is swelling in optic nerve damage, what will happen? There will be veins involved, because the veins will be compressed in the swollen fluid. And once there will be veins involved, what will happen? It will cause hemorrhage. And once hemorrhage will cause, and once there will be some nerve fiber loss or nerve fiber exoplasmic, this what will happen? It will cause cottonwood spots. Cottonwood spots. Because cottonwood spots are due to what? They are due to flow in the exoplasm. Once it is obstructed, they are formed because of that. And the exudates are formed by the leakage by the vessels. So there is the exoplasm problem, there is the nerve fiber problem, and it can have also hemorrhage or hard exudates formed around the macula also, and they are called macular fan. That's called macular fan. So basically, it's a mechanical effect. CSF pressure is raised, then it goes along the optic nerve, it presses it directly, mechanically. And once it crosses the cribriform plate, what's called lamina tuberosa, the striations in the sclera, once it passes, it compresses it, and they affect the ectoplasm of the nerve fibers. And because of that, there is swelling of the nerve fibers, and then once there is swelling, there is the vessel engorgement, there is the veins obstruction. Once there is veins obstruction, there is hemorrhage, and once there is ectoplasm, there are cotton spots. So they all add up, and there of course also ischemia because of the even vascular compromise by the swelling of the optic nerve head. So now this patient comes to us. This was the pathogenesis and they were the causes. Now I will go directly to the presentation. How now patient is coming to our OPD, how we see. His vision will be normal most of the times. That differentiates from optic neuritis. So patient is coming to our OPD and vision is normal. Okay, now we have to ask symptoms. What symptoms will you ask? What are the symptoms of papillitis? Don't see on this slide. Tell me what are the symptoms of. Number one symptom is they have headache, which is in the morning. Which is in the morning while awakening from the bed. Morning headache. Morning headache. It is found in almost 90% of the times. Okay? Number second symptom is what? Visual obscuration. Temporarily sort of a loss of vision. As the vision goes. It is around 68% of people. Then third, they can have one is they can have this headache. Number second, I told you they can have what? Loss of vision. They can have temporary loss of vision. Number third is they can have sometimes photopsia, flash of light. They can have flash of light. There was one more symptom I forgot. And one more important thing is I told you that any nerve compression can cause. Because once there is a CSF pressure increases, which nerve will be compressed? Point for 6? Get up, point for 6. You are right, get up here. So 6 nerve gets compressed and there can be diplopia because of that. There can be, because 6 nerve has a long course. It has a long course. Once there is increase the CSF pressure, it presses it against the virus. So there is a temporary 6 nerve palsy. So temporary 6 nerve palsy. That's called. That causes what? That causes diplopia. So now we have established these are the symptoms, this is the pathogenesis, and these are the causes. Now, what investigations to do? First of all, I told you record blood pressure. Okay. Then number second, you will again do optic nerve function tests. Visual acuity, you will check. Pupillary reaction, you will check. Okay. Second, color vision, you will check. color vision will be abnormal. Okay, even if visual acuity will be 6, even if visual acuity will be, how we check the color vision? We check on the Ishihara charts. We see the one eye and the other eye. Suppose out of 20 templates, if one eye is having 20 correct answers in 20 templates, other will have only 5 answers out of 20. So they have altered color vision. Then the contrast sensitivity will be also abnormal. What will be the visual field effect in there? What will be the first visual field effect? Increase in the blind spot. Increase in the elongation of the blind spot. Because there is an optic nerve swelling. The optic nerve is responsible for a blind spot in the visual field. So once there is enlargement of the optic nerve, it will cause an elongation of the blind spot. Then they have one more result called infranasal step. Infranasal step. So it will be a scotoma in the infranasal region. Then you can have one infranasal, then you can have generalized constriction coming from the periphery gradually. So first of all, elongation of the blind spot. Number second, infranasal step. Then constriction of the visual field as it goes. Then these were the visual fields. Then what other investigation we can do? B-scan. We can do a B-scan is a very important investigation. B-scan we generally
Delete that one.
so, but that is really normally done here. But that's one of the investigations which can be done. Because what will our CT show? It will show a raised disc. It will see a raised disc. And then if you document fluid behind the sclera or behind the sclera on a side of the optic nerve, that suggests to optic edema. Then one more investigation, very important investigation is the CT scan or MRI. Because we want to see what? Posterior fossa tumors. We want to see posterior because tumors is the most important cause of papillitis. So especially if there are posterior fossa tumors, so we want to see MRI, we want to see the CT scan of this patient. Then once we have done MRI and CT scan also, then what we will next do? We will see now how we can treat many patients. How we can manage this. Suppose there is a posterior fossa tumor. We will send it to the neurosurgeon. We will send it to the neurosurgeon. Suppose there is hypertension. We will control the hypertension. Okay. Suppose there is idiopathic intracranial hypertension. What is done in idiopathic? What is the drug of choice in idiopathic intracranial hypertension?
Acetazolamide.
Acetazolamide. Acetazolamide is given 250 milligram BD or TID. And there is one more treatment that's called weight loss. What's called weight loss. So they should reduce the weight because it's found in young girls or young boys. So reduction of weight, acetazolamide. And number third, restriction of salt intake. Restriction of salt intake. So your salt should be decreased. Your salt should be decreased. So these are the three things done. Suppose there is venous thrombosis. What you will do?
Anticoagulants.
Yes, we will give anticoagulant. If we see the clinical presentation, if we see the clinical presentation of the papilliedema, what are the signs? There are two signs. One is the mechanical, one is the mechanical, other are the vestibular. So what are the mechanical signs? Once something comes, pushed it, what will happen? It will be raised. It will be raised. So there will be disc swelling. Number second, there will be disc margin that will be obliterated. There will be blurring of the disc mark. Then number third, there is a physiological cup which will get obliterated. Which will get obliterated. Number four, there will be some edema around the optic nerve head. That's called peripapillary retinal edema. So it is not only the disc. If it is only disc elevated, it can be something else. Then you can have vascular signs. What are vascular signs? There is vascular engorgement. There is venous engorgement. There can be hemorrhage. There can be exudates. Hemorrhage and exudates. And what else? In the chronic, you can have optociliary shunts. There will be a collateral circulation, and you can have some deposits on the optic nerve head. And lastly, you can have an optic atrophy, which will be a white disc. So initially, if we see early papilledema, what will be? Vision 6-6 both eyes. Vision 6-6 both eyes. You see the optic nerve head. There is a hyperemic disc with the blurring of the disc margin with the peripapillary edema. So we label it as early papilledema. Now, second is established papilledema. There is established papilledema. What is established papilledema? Now, there is total blurring of this margin. The optic disc is very released. There is venous engorgement. There are hemorrhages. There are exudates. Okay? So, this is labeled as established papilledema. I cannot keep it incomplete. How can I keep it? So I will tell you like this one. So I have to just tell 2-3 things more, that's all. I have almost finished it. So after established papilledema, what is the next? That's called chronic papilledema. That's called chronic papilledema. Silence. So chronic papilledema is once the disc is also raised, grossly raised, but there are some optociliary shunts. There are optociliary shunts, and there are some amorphous deposits, crystalline type of amorphous deposits on the disc. So that is a chronic papilledema. Even in chronic papilledema, you can have a normal vision. So vision is very limited. And lastly, we have the atrophic type of papilledema. In the atrophic papilledema, the disc will be totally pale. This will be totally pale, though it may be slightly raised, but vision will be now grossly affected, and pupil reaction will now be affected. So, but it happens only in atrophic papilledema. That is the last stage. So, I will revise this again: early, established, chronic, and atrophic. एक टैग करते हैं ये papilledema. Let's wait. So this is type of atrophic papilledema. This is the pale disc, and this is papilledema. Atrophic. So here you see silence. Oh, mister. आपको बात देगा भाई बोलो so this is right place and this vascular involved on all sides and if this is raised how much therapeutic power it will change if it is raised 1 mm it will cause 3 disc diameters how much 1 mm raise is 3 disc diameter. I will advise you lastly, this is the last sentence for this topic, that all of you should have some idea what's papilledema. You should see someday what's papilledema. Okay, all the best.